Assalamu alaikum. Auzu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Now, mania, hypomania, bipolars, depressions. These things will be discussed now. For mania, you should remember 31, and for depression, you should remember 52. These things I will discuss it later. What is manic? What is mania? It's a distinct period of abnormally and persistent, elevated, expansive, and irritable mood. Persistent, irritable, expansive, and elevated mood, increased activity or energy. Diagnosis requires marked functional impairment. 3. Diagnosis requires marked functional impairment with 3 or more than 3 of the following for more than 1 week. What should we remember? Dig first. Distractibility, impulsivity, or indiscretion. That means seek pleasure without regard to consequence. Hedonistic. He's doing some crazy stuff for getting pleasure. He does not know the consequence of doing so. Like he's beating somebody and he's laughing like a hell. So he's just getting pleasure, but he does not know the consequence. Distractibility, impulsivity, grandiosity, thinks that he is the greatest man in the earth. He has inflated self-esteem. Flight of ideas, activity, increase goal directed, and agitation, which is psychomotor agitation, and increase goal directed activity. Decrease need, sleep, don't need, and talkativeness. So this is manic. This is manic. If we get these from these seven if we get three or more than three for more than 1 week, we can consider it as we can consider it as manic episode. Like in acute mania, there is elevated and there is elevated irritable labile mood, increased energy and activity, decreased need for sleep, pressure speech, racing thought, distractibility, grandiosity, risky behavior, marked impairment, and may have psychotic syndrome. For management of these acute mania, for first of all, in acute mania, antipsychotics, first and second generation antipsychotics can be given. Lithium can be given, but avoid in renal disease. Valproate can be given, but avoid in liver disease. Combination in severe mania, antipsychotic plus lithium, or antipsychotic plus lithium or valproate and adjunct benzodiazepine for insomnia and agitation. All total treatment is given in here. In acute mania, first and second generation antipsychotic should be started if he has if he doesn't have any sort of renal disease. Lithium can be used. It's a mood stabilizer. Valproate can be used. It is also a mood stabilizer, but cannot be used in liver disease. And you can do combinations. and adjunctive benzodiazepines for insomnia and agitation. Benzodiazepine as a for insomnia, you can give at least 21 days at a stretch. Then you can taper this drug. In here, it has been said that first line treatment for mania include antipsychotic. First line treatment for mania include antipsychotic like olanzapine and lithium, and anticonvulsant can be given. Anticonvulsant can be given. Okay, next one is hypomanic. It is similar to manic episode except mood disturbance is not that severe enough to cause marked impairment in social or occupational functioning to necessitate hospitalization. It lasts more than 4 days. It lasts 4 or more than 4 days. There is no psychotic feature here. In mania, there may be psychotic feature. In hypomania, there may be no psychotic feature. In hypomania, there will be no psychotic feature. Already I have discussed this. If there is severity is impaired psychosocial function, may have psychotic feature, may require hospitalization. In severity, these are the things you have to remember. I'm looking for something which is very important, difference between mania and hypomania. If I found this, that would be very helpful. Okay, like bipolar disorder, what happens in bipolars? In bipolar disorder 1, it requires one type of episode, one or more than one manic episode with or without hypomanic and depressive episode. May be separated by any length of time, may be separated by any length of time. It has no specific time duration. Suppose a person has a depressive episode for 20 years ago, then after 20 years, uh, after after these 20 years, for last 1 week he showing the manic episode for more than 1 week. Then you should consider it as a bipolar 1. In bipolar 2, requires two types of episode, that means hypomanic and a depressive. Hypomanic and a depressive episode. No history of manic episode. This is high L. There is no history of manic episode. So in bipolar 1, one criterion should be needed, one or more than one manic episode. Manic should be one or more than one, with or without hypomanic or depressive episode. In bipolar 2, a hypomanic and a depressive episode. In here, atypical antipsychotics I have already discussed, and mood stabilizer, atypical antipsychotic olanzapine, and mood stabilizer lithium, carbamazepine, sodium valproate, and lamotrigine can be given. Lithium not used in renal disease, valproate not used in liver disease. Can be combination can be done. And in this, there is a unique disorder called cyclothymic disorder. In cyclothymic disorder, if more than 2 years of bipolar symptom is present, milder form of bipolar must last for more than 2 years, must last for more than 2 years with symptom present at least half of the time, with any remission lasting than 2 months. Symptom must persist for more than 2 years, and there is no remission less than 2 months, with any remission lasting less than 2 months. Then MDDs, major depressive disorder. In MDDs, we actually said that it is 52. That means 5 out of these 9 feature for more than 2 weeks. For more than 2 weeks. What are those 9 feature? What are those 9 feature? What are those 9 feature? The 9 features are dick space, that means dis, depressed mood, interest lost, guilt or feeling of worthlessness, sleep disturbance, suicidal ideation, psychomotor, retardation or agitation, appetite loss, concentration loss, and energy loss. From these 9, if you get 5 or more than 5 feature for more than how many weeks? For more than 2 weeks, MDD can be said. You can consider is as MDDs. Screen for previous manic or hypomanic episode to rule out the bipolar disorder. CBD, SSRI are the first line. An alternative include SNRI, metrazapine, bupropion, ECT, ketamine can be given. Ketamine causes dissociative anesthetics, and ECT can be given in MDDs. A response to a significant loss, bereavement, natural disaster, disability may resemble a depressive episode. Diagnosis of MDD is made if the criteria are met. MDD with psychotic feature. He has major depressive disorder and psychotic. There is delusion and hallucination. If MDD with delusion and hallucination, diagnosis done. MDD with psychotic feature, but in sh- but in schizoaffective disorder, he has more than 2 weeks of psychotic feature, that more than 2 weeks of delusion hallucination, but no manic or depressive, mood disorder no mood disorder. The difference between schizoaffective and MDD with psychotic feature is MDD with psychosis, the main is major depressive disorder plus he has psychotic feature, that means delusion hallucination. But in schizoaffective disorder, he has schizophrenia, that means psychosis, delusional hallucination for more than 2 weeks, but no mood disorder. Treatment is antidepressant. Treatment is antidepressant with antidepressant with atypical antipsychotic. antidepressant for MDD, and as there is psychotic features, so atypical antipsychotic can be given ECT. If you understand the concept, it's easy to diagnose a psychiatric disorder. If you don't understand the concept, it's a very, very, very tough to diagnose. Persistent PDD, persistent depressive disorder, also known as dysthymia. Dysthymia, persistent depressive disorder, also known as dysthymia. More than 2 years of depression, more than 2 years of depressive symptom lasting. More than 2 years of depressive symptom with any remission lasting less than 2 months. More than more than two depressive symptoms, more than two depressive symptom lasting more than 2 years, lasting more than 2 years, with any remission lasting less than 2 months. MDD with a seasonal pattern, MDD with seasonal pattern, formally called formally called seasonal affective disorder. Seasonal affective disorder, in here there is major depressive episodes occurring only during a particular season, occurring only during a particular season, usually winter, in two or more than two consecutive years, and in most years across a lifetime. Atypical symptoms common: standard MDD therapy and light therapy. Standard MDD therapy and light therapy. Depression with atypical feature. It is characterized by mood reactivity, transient improvement in response to positive event, transient improvement in response to positive event, hypersomnia, hyperphagia, latent paralysis, mm, heavy feelings in arms and legs, heavy feelings in arms and legs, long-standing interpersonal rejection, sensitivity, most common subtype of depression. Treatment is CBT, SSRI. At the first line, MAO inhibitors are also effective, but not first line because of their risk profile. MAO inhibitors are effective. Depression with atypical feature, CBT and SSRI are the first line. Depression with atypical feature like hypersomnia, hyperphagia, latent paralysis, long-standing interpersonal reactivity. This is all about manic, deep MDD, and bipolar. Hope you enjoy.